Welcome back to the Toe to Toe podcast, the Flatfoot edition. This is episode 2. We're going to be talking about the adult flatfoot, and I'm back with my esteemed panelists, Dr. Bryon McKenna and Dr. Phong, and we're going to jump right in. So, folks, let's talk about adult acquired flatfoot. I mean, I think we've seen plenty of patients in our office who come in with this progressive deformity that's impeding their daily activities, impeding the weekend warrior, the pickleball, the tennis, and everything else they want to do. Phong, tell me how you evaluate this adult flatfoot deformity.
I mean, the patient comes in your office for a reason, right? They're in pain. That's why they're coming out to see us. So for me, getting a full history, I think, is key. How long have they had this pain? What have they done for the pain? Have they tried some conservative treatment? So I think those are always good key points in trying to figure out what they're trying to gain out of coming to see you. If they're not thinking about surgery, that's fine. I mean, you're there to help them as a physician to get them better, in a sense, right? They're there for help. So for me, custom orthotics, I think, is huge. For these adult ones, I think another option could be a custom AFO if they're not ready for surgery. Those things can be challenging, though, as most of my patients don't like wearing them. But I feel like it's a good option to try. If they fail it, at least we've tried it. And then from there, we can kind of determine what the next step is, if surgery is an option, and go from there.
Awesome. What about you, Bryon?
Yeah, I mean, so I agree with, conservative. You gotta exhaust it. Custom orthotics, AFO. I practice down the bayou, so my patients, that when I give them an AFO brace, next thing I know, they're using it to hold their fishing lures, or they're catching gators with it or whatever. So they're using it more for that than they are for actually on their ankle. But you got to at least try and see. Yeah. So that's always a challenge, patient compliance. And then the other thing we talk about is physical therapy. Again, I'm usually pretty adamant about that. They at least got to try some form of therapy. And then if it's, it's still bothering them, then now we're talking about advanced imaging. And then if this is something that we really need to address and have the conversation with them that, look, this is something that truly you can live with this. We know it tends to be progressive, but this isn't going to kill you. It's just a matter of, how much pain are you willing to tolerate? And then is it starting to slow you down, preventing you from being active?
Yeah.
I think that one of the things, one of our main roles is really to try to keep our patients active. We know as they age, if they're not active and it's something like this that's preventing them from being active, then we're really doing them a disservice by not addressing it.
Agreed. When we talk about nomenclature, Phong, let's talk about sort of the newer nomenclature when it comes to flatfoot deformities.
Yeah, so I mean, flatfoot's been around forever, right? And there's so many classification systems out there. So Meyerson out of FAI just came out with a newer one in regards to classification system, talking about nomenclature as well, out of FAI in 2020. So it's pretty much categorizing what we already know, and besides the flexible flatfoot versus the rigid flatfoot. And they're just adding all these other components to it, which has been around that we've addressed, but there's certain parts that we haven't really addressed. Like, are we looking at just the foot? Are we looking at the rear foot? Are we looking at the ankle? So all these things, I think, play a huge role. So knowing the classification systems do help in kind of, in a sense, staging on how you plan to fix this, whether it's flexible or rigid.
Agreed. I mean, I think definitely having a plan is necessary, but as you guys have seen, there's always plan A, B, C, and then Z, because you have to be prepared to do any number of procedures to get the correction you want, right? So when we're evaluating these patients with the adult flatfoot, we're definitely, obviously, ordering imaging, we're taking x-rays. So I have a case up here. Bryon, why don't you tell us what you're seeing on this particular x-ray?
Yeah, so, I mean, you can tell skeletally mature, growth plates are closed, but you can see quite a bit of frontal plane deformity. You see that talar head uncovering on the AP view. Other things that I see is abduction through the calcaneal cuboid joint. The forefoot is abducted. And then also a little bit of an increased IM angle where a patient has a little bit of a bunion, prominence to the medial aspect of the first metatarsal head. Sesamoids are sitting into a slight abnormal position. On the lateral, you have actually a fairly significant plantar flexion of the talus. Calcaneal inclination angle is not terrible, but that talus is really sitting into a plantar flex position. You have an accessory bone, an osteotibialis externum to the medial aspect of the navicular that's present there as well. And you can see that first ray, obviously Meary's angle is significantly abnormal. And the first ray elevated to some degree. There's a little bit of gapping to that plantar aspect of the first TMT as well, which to me indicates that they're forefoot overloading and that really that there's some instability through that joint. And then we have a AP of the ankle, which to me, this is such an important X-ray, because really what I want to look at is what position is that talus in the ankle mortise. Is it sitting, significantly valgus? And one of the things that I've really come to appreciate is that in something that's a little bit more rigid is oftentimes you'll see an ankle X-ray just like this, where the talus really, looks like it's congruent in the mortise. Not seeing a whole lot of varus or valgus or that, but what you're missing is that it's getting kickstanded against that lateral malleolus. And so what I look for is actually some widening between the tibia and the fibula, which indicates that it's kickstanding against the lateral malleolus. And to me, that indicates the deltoid ligament's out. And so that's something that I've been fooled on X-rays, and I've learned that from the school of hard knocks. And so I'm a little bit more cautious. I don't necessarily see it in this one, but just a point that I bring up. But otherwise, the talus is sitting congruent in the joint there.
So, we see a lot of pathology on this X-ray, right? Mm-hmm. How do you know when to say when? What procedures would you pick and do? Do you consent this patient for every procedure from ankle, hindfoot, forefoot, midfoot? Are you putting this in your consent that we're going to do any number of these?
Pretty inclusive in my consents. I think that you want to have that tool available to you. And I think that y'all said it the right way, which is you kind of go in with your plan A, but understanding that chances are, that's going to go out the window. And the famous saying is the first casualty of war is plan A. Mm-hmm. So you got to have something to back up to. And so that's what I kind of go into it with that mentality. And one of the things that I love about these procedures is that it's a stepwise approach. So it's one step, and then let's see what we have, and then take the next step. And that decision making is, to me, is kind of what makes it fun. Is that you're really making that decision as you're going for this. So for this case, it depends on if it's flexible or if it's a rigid deformity. That makes a difference. Patient age. And then BMI can make a difference. There's a lot of things we can kind of go into as far as procedure type, and then patient expectation. I think that's the biggest conversation is what are they expecting? What are they trying to get out of the surgery? Can I accomplish it with a brace, or, are we at a point where we got to fix it?
So what would be your plan, A or B, Phong, on this particular? Assuming it was flexible, semi-flexible.
Semi-flexible, okay. Yeah. All right. So, flexible deformity like this, I'd probably start in a calcaneus, maybe doing a calcaneus slide osteotomy at first. I don't know if I would really do an Evans on that, just because I see some transverse plane deformity there, but I'd have to take a look. I'd still open medially because I think there is probably some posterior tibial dysfunction or some pathology going on there. I think a quick test that you can do in the office is see if they can do that heel rise test, if they can or cannot. Compared to contralateral limb, is it swollen, is it painful in palpation, all key components to determine what you're going to do medially. If it's just going to be a Kidner type of procedure where you're advancing a posterior tibial tendon, do you need to do a flexor digitorum longus transfer? Do you need to augment the spring ligament? And what Bryon said, I think, I don't really see it on this X-ray in regards to ankle, but yeah, you can definitely get fooled by the deltoid, because I think there is a component of the deltoid that does wear out over time with these flat-foot deformities.
And you're ordering advanced imaging, so you should be able to evaluate whether that deltoid is intact or not, or if there is truly posterior tibial pathology, right?
Yeah.
So I almost always, as a rule for me, is advanced imaging for the adult flat-foot. More than likely it's an MRI, because I really want to look at soft tissue predominantly. If there's anything on MRI that's suspicious for any sort of significant arthriticity happening in the subtalar joint or any of the joints, then I will order a CT as well.
Yeah.
With reconstruction. I just think it's the best way to have the best plan or version of plans.
Definitely.
I think one of the other things that I notice on this one too is there's two things. Is if you look at the talus, that it's sitting a little bit anterior. It's slight, very slight, but on the lateral, I feel like you got a little anterior lethesis of that talus, and then that plantar flexion of the talus where there's a little bit of gapping to the dorsal side of the TN joint. What I've noticed over years of doing this, really looking at, I've gone pretty deep dive into the spring ligament. One of my mentors at OFA, Dr. Boll, he and I did a deep dive in this one, and he's really the brains behind it. But looking at the spring ligament, that's what we noticed was when you see that plantar flexion and that little bit of a step off at the TN joint on the lateral, that almost every time that spring ligament's gone. And so without an MRI, that's just little clues that I see that kind of help guide which way I'm planning on going before I get my MRI.
I think when you're evaluating for spring ligament, that's a call to the radiologist. I think you have to discuss it directly because most of our radiologists aren't looking for it, number one. Yeah. Two, unless you really point it out or are seeking the integrity of that ligament, you're never going to get that answer. When you're talking surgically about your approach, how are you approaching that spring ligament? How are you finding it? What are you repairing it with?
Yeah, so it's through a medial incision. Oftentimes I'm taking down the posterior tibial tendon, reattaching it or flying it, and we can kind of talk about when we decide to do that versus not. And then as soon as I get down past the post-tib tendon, you can stare basically right at the spring ligament. Yeah. And what I'm doing, usually a direct repair to some degree, or attempt to with Ovicral, and then I use a synthetic graft to augment it. So I do very frequently, almost every time with my flat foot deformity, I do some augmentation of my deltoid ligament. So I do a construct where I reconstruct both the deltoid ligament posteriorly, anteriorly, and swing it under it to reconstruct the spring ligament to give it that sling effect to try to get that talus up. And that's been really a game changer. And what I do is I drill into the navicular, and oftentimes I'm doing an FDL transfer with it. And the reason I do that is I'm using that FDL less as a dynamic strut, but more as almost a static augmentation to my spring ligament repair. Because you lose some strength with it, and then also obviously back up my post-tib tendon. But almost every time I'm doing that now.
And what type of anchor or fixation are you using? Are you using a tenodesis screw?
Yeah, so I'm using a tenodesis screw, oftentimes G-force or some type of a tenodesis screw with the graft.
Got it.
Interesting.
So this particular patient underwent MDCO, Evans, and first met cuneiform fusion, right?
Yep.
And then it looks like you put an anchor in the navicular as well.
I did.
Yeah, got rid of the accessory bone. I mean, it looks like a great correction. I mean, I agree with all of it. I struggle with the patient when a plate that size, if this is going to be problematic in the future, is this person going to feel this? What's your post-op on this type of case? How long are they non-weight bearing?
Yeah, I keep them non-weight bearing for usually 4 to 6 weeks. 6 weeks they start walking in a boot, and then my plan is to get them into physical therapy before 9 weeks to start rebuilding that. But and then a lot of that more to do is I really want to protect the soft tissue repair, that medial soft tissue repair. But I'm one that I want to get them walking as soon as I can, but when I'm doing all that deltoid repair, I want to protect it.
What's your post-op on these types of patients?
Yeah, so most of my patients for flat foot, I'll do 2 weeks in a splint, posterior splint, just in case it swells up, and then I'll usually cast them for about another 4 weeks. But it depends on the patient. I think sometimes I'll put them into a cam boot if I trust the patient, because I mean, if you can get them moving in regards to range of motion, if you didn't do an Achilles work, you at least keep the ankle range of motion, the foot and the toes going. It helps with their post-op course and recovery so much faster, but you have to make sure you trust the patient.
So you practice in California, where I practice on the bayou, where we have people, we call them tête dure, which means that they're hard-headed. And and if I put them in a boot, they're going to be out shrimping next day, walking all over it. So I got to cast them and cast them from the neck down. So.
When you say, he's saying bayou, because I can't understand it, but he's saying bayou, so okay. I don't know what the other word was. But yeah, in New Jersey, we don't trust our patients either, but that's just because our patients are hard-headed as well.
Yeah,
yeah, that's it. That's the word. So for our next case, let's talk about the x-rays that we see here. I think Phong, do the honors for us.
Yeah, sure, yeah. So on this one, you can definitely see some talar head uncovering there. There's a little concern for maybe some arthrosis at that joint there, the TN joint. I mean, calcaneocubital angle is not too bad. I don't see too much transverse deformity in this forefoot. Patient does have a mild to moderate bunion deformity, I would say, with an increased IM angle. Lateral view, I mean, you can definitely see there's a decreased Meary's angle. Talar calcaneal angle is also decreased as well. The calcaneus is flat, almost like a pancake, but pretty close to it. And then you see the calcaxial here. You kind of see there is some valgus deformity in the heel as well. So that's what I see.
What's your surgical approach to this particular patient? I would say this is more rigid. You're not able to get full eversion, inversion at the subtalar joint. What would your plan be?
Yeah, for me, obviously comorbidities and everything, but essentially this is going to be a medial double for me. That I go through the medial side. I'm going to fuse the subtalar joint, the TN joint, plus or minus a cotton, depends on if I need it. I've been adding a little bit more of a cotton to even my medial doubles. And again, a lot of that it depends on its stepwise approach. After I get everything lined, if I feel like I need to get that forefoot supinatus out a little bit more to protect some of that medial soft tissue work, then I'm doing that. But I'm swinging that over through the subtalar joint, the TN joint, and plus or minus a cotton. And then medial work based on what that post-tib tendon looks like, either completely getting rid of it, reattaching it with the FDL transfer. And then the other thing is every time I do a medial double, I'm augmenting my deltoid repair. I've had a few too many medial doubles that before I was doing that it would tilt into valgus. And that was always the biggest complaint about a medial double was to get access to those joints, you got to go through the deltoid. And so in my opinion, I think that if you're doing a medial double, that's great. There's a good indication for it. There's times where if that deltoid isn't out, and I don't have an AP of the ankle, so it's kind of hard for me to tell, but if I feel like MRI doesn't show me the deltoid's out, but we're arthritic like this, then I'll actually do a 2-incision approach. I'll go lateral subtalar joint fuse it and dorsal to the TN joint fuse it and avoid, and then go obviously medial to the post-tib tendon, but I'll avoid going through the deltoid ligament. Nice. And so, and admittedly, that's more of a rarity for me. More often I'm doing a true medial double, but I think that's an indication here. But so probably a true medial double for me. Leave the CC joint alone.
What about you, Phong?
I believe this is one of my cases. So for me, I believe I did a TN and subtalar joint arthrodesis. I didn't do the CC joint. Oh wow, yeah, I remember this case now.
It's all coming back?
It's all coming back, yeah. So I also fixed her bunion. Wow, okay. Yeah, we did a lot on her. So subtalar fusion there, as you can see, I always like to position it first. Once you get I like to do a double incision approach. That's how I was trained. I feel like, for me in my hands, I feel like that works better for me, just so I can see that posterior set, get that posterior rim of that area, just to get all the cartilage. And I want to make sure myself and my residents can kind of see that. So once you get the joints prepped, you pin it. I always like to pin the TN joint just to make sure I like the position there. You want to make sure your Meary's angle is improved compared to what you had previously on a lateral view. So once you pin it, then I'll put a subtalar joint screw up there. And at times, you can kind of see on this one, the calcaneal inclination angle isn't as high as I'd like. I believe this might have been prior to me putting bone wedges in. I'm not sure how you guys feel about putting bone wedges in your subtalar joint, like a bone allograft or some type of wedge in order to increase the angle and kind of help with their flat foot deformity.
What's the largest bone graft you've used, a wedge?
I typically use like a 10, but I've gone up to maybe a 12, honestly.
And do you find any issues with fusion, like in your postoperative?
I prep the joints a lot. With these, I put some augment in there, and it kind of helps to kind of stabilize
that magic potion.
That magic.
I love that augment.
Yeah.
How are you prepping your joints for subtalar joint?
So, typically I use the prep kits they have, which has very sharp osteotomes, curettes, and like a 2 or 2.5 drill bit.
Yeah, I love that. The joint prep kit is amazing.
Yeah, I love it. That little drill bit, that little PLP we call it. That's a nice thing. So, but no, it does. It really speeds up your joint prep, and as much as these cases, you're doing a lot of work, and really you're trying to, that's what I always tell my residents, especially in a case like this where you're doing a lot of work. It's amazing you're able to get all that done in one shot.
Setting,
and but I always tell them it's kind of like you're doing an orchestra. You got to know what parts to take your time and get right, and what parts you got to fly through. And I always hear, Phong and I were trained by the same crazy Italian, Dr. Basile. Yeah. And I always hear him in my back of my mind, like, let's go, because that's the part where you got to get that thing prepped and get it going so that you can take your time and get your alignment right. And so something that can speed that along is always helpful.
If you had to do this one again, would you do anything with that CC joint? Did this patient have any lateral column pain? I mean, the joint looks pretty arthritic on the previous X-ray.
Correct. I mean, you could. I mean, hindsight's 2020, right?
Yeah,
so
of course. Yeah.
you can go back and look. You're looking at the X-ray. It's like, yeah, it looks like it's kind of arthritic there. I mean, I might have gone back and done something, but I mean, she's actually doing really good. No pain on the calcaneocubital joint at all.
Yeah. So that's why I ask. I mean, I think as much as we love imaging and we love the diagnostics, we have to treat the patient, right?
Yeah,
So
exactly.
this X-ray, I would say, if this was a board question, yeah, maybe we could have done a triple instead of just a medial double. But with that being said, the patient's doing fine, right? Even if the X-ray doesn't look amazing or picturesque, the procedures you picked corrected the deformity, got her to where she needs to be, right?
I agree.
It looks like you used a combination of headless screws, small staple, small plate. Is that your go-to construct, typically screws and staples, or what's your go-to for fusions?
I do like the 2-screw construct, and I started adding a staple on top of it. This is one of the older staples, I'd say. This is a thinner staple. The newer staple, the Easy Fuse, is amazing. I think that's so much stronger, and it helps quite a bit. If I can't get the 2-screw construct, I might do 1 screw and 2 staples. So I'm not
Do you ever use the TN plate?
I've
Like
seen
from
it.
the Variac
I
set?
probably have tried it once or twice, to be honest, but I feel like I like this compression better versus a plate. And it's always, if you can see the APV here, I feel like that lateral aspect of the TN joint, it takes forever to fuse. So I feel like, I don't know if the gingerbread man plate would be able to sufficiently do that for me in my hands. So I always like to percutaneously throw that screw. Yeah.
I agree with that. That's the hardest part of that fusion. I think prepping it, accessing it, getting around the curvature of the talar head and making sure all that cartilage is off. Do you do 2 incisions for this? Like, are you making it separate?
I do. I do 2 incisions to make sure I get access to it. For me, I just like to see it. I mean, for all the residents and fellows listening, I think it's really important. Joint prep, like we talked about earlier, like Bryon said, like you gotta get the joint prep really well, but you have to do it efficiently. You gotta do it quick because it's a long case, right? So if you don't get the joint, get the cartilage out, this thing's not gonna heal.
How long do you think this case took you?
Oh my God, probably like 4 hours because I was training residents, so probably even more, so I don't remember.
It probably took 4 hours to close.
That's right, true.
Staples.
I see the one gray hair on your head from this particular patient.
Oh, yeah, definitely.
But I think the outcome was really good when you look at the X-rays, and thankfully the patient is doing well.
I think a couple points on that too is the CC joint, the arthritis there. That really, and I agree. I actually wouldn't have gone after that CC joint. I think that when you diastase the CC joint, it offloads that, and my patients don't have pain with that either. Even, I mean, you saw it preoperatively and postoperatively, and yeah, you don't like the way the X-ray looks at there, but the patient's not complaining of pain, and you saved them a fusion. And then the other thought was your fixation across the TN joint. So I kind of went through that same thing where I was doing 2 crossing screws. And I had a couple non-unions, mostly on the dorsal side. So I switched and added a staple to it as well.
So one more question about this particular, let's go back to the preoperative X-rays. So now that you've been kind of dabbling with MIS techniques, right? Let's say you did this today, this particular case. What would you do MIS? What would you do open? Would you prep the subtalar joint, TN joint MIS?
I think that's I think it's definitely a good option. I mean, now we're trying to, patients want quicker recoveries, smaller incisions, and we always want them to have a quicker recovery as well, right? So less swelling in general. So for me, I think different. I mean, I probably would possibly consider maybe doing, like Bryon said, maybe a medial double with trying to not damage the deltoid if you can. Sometimes that's challenging. But if we can get in there, we can see what we need to see, even with either small incision or mini open incision with the burr. I think that does help, and prep the joint accordingly. I mean, in regards to the heel there, you see the heel's slight valgus even after the correction. Even though I slid over the calcaneus, I probably would have done an MIS calc slide in addition to a subtalar fusion with this case.
Yeah.
I think MIS joint prep to me worries me more than anything because we were just talking about it's hard to get over to that lateral side with it open, let alone try to get a burr over there. So that's always been my biggest concern with doing MIS joint prep is how do I know that joint's prepped the right way? So I want to see it. Like I said, I like the warm and fuzzies. I want to know that I got that thing prepped. And
I think once you start getting your hands on it more, I think you're going to like it where you can kind of irrigate as you irrigate it, all that stuff's going to come out over time. And then the only downfall, I think, with MIS, of course, is numerous images, right? So you're using more fluoro. So you got to make sure on the fluoro, does that joint look prepped? Because you're not putting a big distractor in there. You can't with a minimal incision. So I think that's going to be the key, and we'll see what the future holds.
Yeah, I mean, I think definitely cadaver labs. Practice.
Exactly.
Practice and make sure you're comfortable. I think with the TN, for sure, if you're not doing these regularly, then I would say standard approach, open, make sure you're visualizing, prep that joint.
Exactly.
Do your drill holes, use your joint prep kit, and then fixate any way you want, maybe a plate or 2 crossing screws. So let's look at this particular patient here. Bryon, tell us about him.
Yeah, so pretty standard flat foot. You can see increased talar head uncovering. Looks like there's an ostibialis externum to the medial side of the navicular, abduction through the calcaneal cuboid joint. You see some flattening of the calcaneus. The talus is sitting mildly plantar flex. I mean, Meary's angle is off, but it's really not severe on that lateral view. And then we have the calcaneal axial view where you can see sitting a little bit of valgus. I wouldn't say severe valgus, but a lot of that deformity really seems to be coming, through the TN joint and the CC joint where the forefoot's abducted.
So Phong, this particular patient, let's say, is a 60-year-old active plumber. That's his job.
Okay.
How do we approach this surgically?
Would you say this is rigid, flexible still?
I'd say rigid, maybe semi-flexible, but some arthrosis you're seeing on X-ray.
Yeah, so if that's the case, I mean, you can kind of see that it's a slightly bigger leg, not ginormous, but what they are concerned for arthrosis with advanced imaging, which I assume we would have already obtained.
Yeah.
Honestly, I'd probably at least do a double arthrodesis with this, with TN subtalar. And then from there, like we talked about medial work, do you need to do something with the posterior tib? I think that's up to debate, right? In regards to, do we debride the posterior tib? Do we resect the posterior tib? I'm not sure what you guys like to do, if there is pathology there.
I'm not resecting. I haven't traditionally resected posterior tib. Definitely repair, debride, tubularize, or wrap, advance, all the standards. Kidner, with this one, I'd probably do a Kidner advancement procedure.
Yeah.
What about you? Are you resecting the posterior?
I am. Not every single time, but I will. I know. It all depends on what it looks like intra-op. We try to use the MRI to guide our incoming with a plan, but it depends on what it looks like intra-op. And if that tendon is extremely thick and torn and it goes all the way up, in my opinion, that thickened tendon, even if you try to clean it up, and I'll try to clean it, and if it's just completely torn through, it's that thick fibrotic, just garbage tendon, and I really don't have much good tendon to work with, I'll fly it. I'll resect it as far up as I can, and then I'm transferring the FDL, and I'm using my deltoid ligament to hold that over. And but I'll only do that if I'm fusing.
Yeah.
So I have, you have to fuse. You have to. So once you make that decision to fly the tendon, I mean, most of the time that's a medial double fusion, anyways. But if I can save it, I will. But I say probably 40 to 50% of the time, even as high as that sometimes.
Wow.
Wow.
I'll fly it.
It's wild in the bayou.
Wild in the bayou.
Love
Yeah.
that. All right, so this particular patient, medial double, right? So I think great correction. I think this was yours, Phong?
Yeah,
Yeah.
it was, yeah. So patient did pretty well. It's nice and stable. You see I left the CC joint open. Patient's doing pretty good. In this case, I mean, I was debating intra-op about the forefoot supinatus. If I needed to do something, I felt like I didn't. Patient ended up doing pretty well, so it worked out.
How far post-op have you seen this patient? Are they seeing any issues in the midfoot or?
Midfoot-wise, yeah, I definitely can see there's some concern, maybe the NC there a little bit, but I usually follow these patients for at least a year out, see how they do, and then after that annually, but she hasn't had any complaints in the midfoot. She feels her arch is higher than it was when we started. And the main thing is, like you said earlier, I think you can't just treat x-rays. I think you gotta treat each individual patient individually in a sense,
Yeah. Bryon, would you fixate this differently?
Me personally, I would have added a medial column. Something with that medial column, I probably would have done a cotton. One of the more interesting things that have come up recently in some of the literature is looking at primary NC fusions. I've always kind of stayed away from it just because it does have a little bit higher non-union rate, and I hate non-unions. So, but there's some research out there, some of the newer literature that's convincing, that we talked about, that you lose some of your correction with your cotton over time. That's kind of ironed itself out in the literature, and so there's some concern for that, right? And if you fuse it, then you're less likely to lose that correction, but you're also making more of a rigid lever arm, and so that can cause some of that. And the other thing I think about is down the road. I mean, you look at kind of the lateral, and you think, well, maybe, I don't know, maybe there's some early arthritic changes in the first MPJ. I mean, really early, but potential, and you now plantar flex that, you're going to more overload that first MPJ, you're going to potentially cause more breakdown. Well, now you have almost a full medial column fusion, including the first MPJ. Right. The only place you have motion is through the TMT, and then that's going to break down. And so it's
slippery slope. Yeah,
you end up chasing it, and I don't know what the good answer is. So, but to answer your question, I probably would have added a cotton just to bring that down. But otherwise, good result.
What's your incidence of non-union when you're doing a subtalar? I know you said you hate non-unions, so the warm and fuzzies are over, Bryon. What percentage of your patients do you think you're getting non-unions on?
My subtalar joint?
Yeah.
Probably 5 to 10%.
Okay, how about you?
Yeah, I'd say similar. I think it really depends on the patient, their pathology, but also comorbidities. I mean, if you're dealing with patients who are high BMIs or diabetic, PVD, things like that, but definitely some concern.
So what's your absolute contraindication? Is there a patient that you would not operate on even though they're still working, they're active, they're functioning? Is there a comorbidity that you'd say, you know what, I think I'll pass on this particular patient?
I'd say for an open approach, I mean, I think I'd operate on most patients, I'd say. I definitely see a lot of the more complex cases in town. I think like diabetic with neuropathy with end-stage renal disease, they just don't heal, and I feel like it's not a great option to open those patients up. That one, if they really had severe pain and needed some rigid fixation, I'd probably do an MIS for those type of patients.
Even on a neuropathic patient?
I would, yeah, because I think even though they're neuropathic, I think it can break down over time, like and turn into like a diabetic Charcot or something. So I think you do need some rigid fixation for those type of procedures.
So if this was a neuropathic patient with this X-ray that we saw, let's assume A1C of 7.6, right, just over your threshold, I think of 7.5.
Yep.
And there is evidence of neuropathy, loss of protected sensation. You've done testing. Would your surgical approach change?
I probably would end up doing a triple versus just a double for this patient. And maybe even, like Bryon said, maybe a medial column fusion just to stabilize it. But if it's like a broken down Charcot, that'd be different. I'd be beaming, right? But this is, you don't see that. You don't see the Charcot in this component in this patient.
Would you ever consider beaming in prevention of, in anticipation of a future Charcot?
That's so hard to say.
It's hard to say.
That's,
I know. I mean, there's a lot of what ifs, but I think this is kind of the thought process of how do we evaluate these patients. We say we're going to do we're going to do additional medial work because we're afraid that something will break down in the future, whatever. So if you have a patient who's diabetic, 7.6, 7.8, right, whatever the A1C is, neuropathic, are we doing too much or are we doing too little? Do we need more hardware? Should we put a medial column plate? Should we use a beaming system? And there's lots of new options out there. And that's a real conversation to have with these patients, right? You have, let's say it's a 65-year-old grandmother who takes care of her kids, right, her grandkids. Are they going to be off their foot for 3 months and get this to heal? And how do they stay off their foot? How do you get them non-weight bearing? What's that post-op look like for you?
Yeah, I think your point on do you medial column beam and prevention, and frankly I have not very often. I can think of 2 cases off the top of my head where the talar head was completely dislocated through the TN joint, and and they're still walking on it, and and your spidey sensors are going up saying a normal person can't walk on that foot, and of course they're neuropathic, and so even though it wasn't truly Charcot, I beamed the medial column because it was going to break down if I didn't, and fuse a subtalar joint. So, like I said, I can think of two on the top of my head that I've done so far that I've done that. So not frequent, but I think that your thought process is right. Is you got to think ahead if they're neuropathic, diabetic, and then these patients that, their diabetes, if it's not controlled, then I won't operate on them. They've got to get their diabetes under control. My threshold tends to be 8, so maybe a little bit more lenient. But also, I've got some bigger patients, and then obviously, vascular supply is such a huge thing. The peripheral vascular disease. I'm pretty fortunate with where I work that I have, very good vascular team around me. I've been in situations where I didn't, and that's a nightmare. Cause I'm dead in the water if I don't have blood flow. So I think those are things. I agree with you. End-stage renal disease and diabetes, then you're just asking for problems. But.
Yeah. Is there any requirement for smoking cessation for your patients preoperatively?
So it's tough. I mean, I prefer not to operate on smokers, but it'd be hard. In the type of practice I'm in private practice, I think you try your best to have them stop smoking prior to surgery and inform them of all the complications, delayed healing, wound issues, all these things that could potentially happen. And if they are willing to proceed, then you can kind of continue to help the patient. But that's up for debate. I mean, we talked about it before in regards to, do we do nicotine screens for patients who are smokers? And then what is our process? Do we make sure that they decrease that amount of nicotine before we jump to surgery? So,
yeah, I mean, to me, it's a hard sell. I think the patient has to have some responsibility in their own care. So we have the conversation. Our protocol is we have the conversation about smoking cessation. We document it. We make sure it's in our note. We actually have the conversation, have handouts, explain to the patient why we're telling them to stop smoking, and then I do not do nicotine screenings. Again, if it's a test that I'm ordering, the assumption is I'm going to do something with that test. And I'm not doing any smoking cessation therapies or anything for this particular patient. But I think as long as there's informed consent and they know that what they're walking into could become problematic if they are smoking. I mean, the worst type of patient in my hands would be a diabetic end-stage renal COPD who's a smoker. Right, who comes up with an oxygen tank. I mean, I think that one I'll send down to the bayou.
Yeah, you can keep it.
You give me the subtalar joint implants back. What about you, Bryon? What about the smoking?
Yeah, I'll operate on them. But I agree with you. I think that one of the things I try to do for my smokers, my larger patients, that if I say I date them for a little bit, meaning I'm probably not gonna book them for surgery right away. I'm probably gonna say, look, I want you to stop smoking or at least show, make steps towards stopping and show me that you're willing to do that. And more than anything, it's not that, we know there's risk with it, and obviously I educate them on that, but it's also gives me a chance to somewhat test them to see how motivated are you to actually follow what I'm going to tell you to do and to be compliant postoperatively and have a good outcome. And like you said, is that they have to take some ownership of their care, because we can't do it for them. I'm not going home with my patients. I don't know if y'all are, but me, I don't want to go home with my patients. So they got to take some ownership.
Basically, you're waiting for the warm and fuzzies to develop.
Yeah, and
then you book them for the case.
That's right. Yeah, that's right. That's right.
I love that. All right, guys, thank you so much for finishing up the second episode of the Flatfoot edition for the Toe to Toe podcast. We'll be back with episode 3 shortly. Thanks.